Good morning and welcome everyone. It is 7 a.m. on the West Coast, 10 a.m. on the East Coast, and this is Grace Lee, Chair of the Advisory Committee on Immunization Practices. Today is February 4th, 2022. It's just 2 days after Groundhog Day, so if you're feeling like this is Groundhog Day, it may be justified. For those of us who follow the groundhog Punxsutawney Phil, you'll know he saw a shadow, and so we will have 6 more weeks of winter. And it turns out, I think he's also predicting the next 6 weeks of ACIP, where we're going to have to keep our heads down, stay warm, and hope for spring break soon. So with that, I'm pleased to call today's ACIP meeting to order, and I'll turn it over to Dr. Melinda Wharton to share today's announcements. Dr. Wharton.
Good morning, and welcome to the February 4th virtual meeting of the Advisory Committee on Immunization Practices. Copies of the slides being presented at today's meeting are or will be available on the ACIP website. Additionally, we make slides available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those of you who are listening to us on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the virtual hand-raising function in Zoom to raise your hand. During the discussion period, Dr. Lee will first take questions from the voting ACIP members and then from ex officio members and liaison representatives. Please disable your video until it's time to vote, and then we'd appreciate it if you could turn on your video during the votes. Next slide, and next slide. This meeting's oral and written, we will be having public comment today during today's meeting. The Advisory Committee on Immunization Practices is, at its heart, a public body. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we will be holding one oral public comment period at approximately 11:10 a.m. Eastern Time. To create a fair and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have already been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0022. Information on the written public comment process, as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflicts of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide. And at this point, I will turn the podium back over to Dr. Lee. Thank you.
Thank you. For the ACIP members, I'll ask you to state your name, affiliation, and whether you have any conflicts of interest. Today, we'll start with Dr. Talbot.
You went totally out of order and totally caught me off guard. Good morning. My name is Kim Talbot. I am a infectious disease physician at Vanderbilt University Medical Center, and I have no conflicts.
Thank you. Dr. Sanchez.
Pablo Sanchez. I'm professor of pediatrics at the Ohio State University College of Medicine and Nationwide Children's Hospital, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's. Thank you.
Okay. Did you say your conflicts? Apologies if I missed it.
Yeah, I have no conflict.
Thank you. Dr. Paling.
Good morning. This is Kathy Paling. I am a professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist, and I have no conflict. Thank you.
Thank you. Ms. McNally. We'll move to Dr. Long.
Good morning. This is Sarah Long. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict.
Thank you. Dr. Lair?
I'm Dr. Jamie Lair, a family physician in private practice in Ithaca, New York, and I have no conflicts.
Thank you. Dr. Cotton?
Good morning, Dr. Camille Cotton. I am the clinical director of transplanted immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts.
Thank you, Dr. Cotton. Dr. Daly?
Good morning. Matt Daly. I'm a pediatrician. I'm at Kaiser Permanente, Colorado. I'm also an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Sineas?
Good morning. I'm Dr. Sybil Sineas. I am an internist and pediatrician. I'm an associate professor of medicine pediatrics at Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Chen?
Wilbur Chen, adult infectious disease physician and professor of medicine at the University of Maryland School of Medicine. One of the hats that I wear is director of travel medicine practice. For full transparency, my employing institution, the University of Maryland, has a grant from Emergent Biosolutions that supports work I do on developing a Shigella vaccine, a diarrheal pathogen. I don't believe that this presents a conflict of interest for our discussions today. Thanks.
Thank you, Dr. Chen. Dr. Brooks?
Oliver Brooks, pediatrician, chief medical officer, Watts Healthcare Corporation. Good morning.
I'm sorry if I missed it, but did you state if you had conflict?
And I have no conflict.
Okay, thank you.
Thank you.
Dr. Bell?
Beth Bell, clinical professor, University of Washington. I have no conflicts.
Thank you. Ms. Bata? Okay, we'll move to Dr. Alt.
Good morning. My name is Kevin Alt, and I'm an obstetrician gynecologist at the University of Kansas Hospital in Kansas City, Kansas. I have no conflicts. Thank you.
Thank you. And this is Grace Lee. I'm professor of pediatrics at Stanford University School of Medicine, associate CMO for Stanford Children's Health, and I have no conflicts. Are there any members who have arrived that I have not yet called on? Okay, thank you. For our committee today, we do have quorum, so we're able to proceed. For our ex officio and liaison members, I will announce the organization name and then please indicate if you're present and your first and last name. First, we'll begin with Centers for Disease Control and Prevention.
Good morning, Dr. Lee. Sam Posner, NCIRD.
Morning, Dr. Posner. Centers for Medicare and Medicaid Services.
Good morning, Mary Beth Hance, present.
Thank you. Food and Drug Administration.
Good morning, Doran Fink, present on behalf of the U.S. Food and Drug Administration Office of Vaccines.
Thank you, Dr. Fink. Health Resources and Services Administration.
Good morning. This is Mary Rubin from the Division of Injury Compensation Programs, present.
Morning. Indian Health Service.
Good morning. This is Dr. Matthew Clark with the Indian Health Service.
Thank you. And National Institutes of Health.
Good morning, John Beigel, present for the representing the NIH-NIAID.
Thank you. Office of Infectious Disease and HIV/AIDS Policy.
Well, good morning. This is David Kim, representing OIDP in the Office of the Assistant Secretary for Health.
Good morning. Next, we'll move on to our liaison representatives, beginning with American Academy of Family Physicians.
Hi, this is Amy Mullins with AAFP, present.
Thank you. American Academy of Pediatrics.
Good morning. This is Bonnie Maldonado, and I'm
Chair of the Committee on Infectious Diseases for the American Academy of Pediatrics and Professor of Global Health and Infectious Diseases at Stanford University School of Medicine.
Thank you. American Academy of Physician Assistants.
Good morning. This is Marie-Michelle Léger from AAPA, American Academy of Physician Associates.
Thank you. American College Health Association.
Good morning. This is Sharon McMullen and Dr. Tavi Chai for ACHA.
Thank you. American College of Nurse Midwives.
Carol Hay, present.
Thank you. American College of Obstetricians and Gynecologists.
This is Dr. Linda Eckert, Professor of Obstetrics and Gynecology at University of Washington for ACOG, present.
Thank you. American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine Private Practice in Florida, also affiliated Associate Professor at Florida Atlantic University, representing American College of Physicians. Pleasure to be here.
Thank you. American Geriatric Society.
Ken Schmader here for AGS.
Thank you. America's Health Insurance Plans.
This is Bob Gluckman, CMO Providence Health Plans, present.
Thank you. American Immunization Registry Association.
Morning, Rebecca Coyle and Beth Perillo representing ERA.
Morning. American Medical Association.
Sandra Freihofer, General Internist in Atlanta and Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Carol Hay, substituting for Chad Riddle.
Thank you. American Osteopathic Association.
Stan Grog, present. Good morning.
Morning. Thank you. American Pharmacists Association.
Good morning. This is Michael Hogue, Dean and Professor of Loma Linda University School of Pharmacy and Professor of Preventive Medicine at Loma Linda School of Medicine, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, representing AIMS.
Thank you. Association for Prevention, Teaching, and Research.
Richard Zimmerman at the University of Pittsburgh, representing APTR.
Thank you. Association of State and Territorial Health Officials. Move on to Biotechnology Innovation Organization.
Good morning, Phyllis Arthur, representing Bio.
Morning. Council of State and Territorial Epidemiologists.
Hi, Dr. Christine Hahn, Idaho State Epidemiologist representing CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis here for NACI.
Thank you. Infectious Disease Society of America.
Good morning, Jeff Tuchin, Health Officer, Public Health, Seattle and King County, Professor of Medicine, Division of Infectious Diseases, University of Washington, representing IDSA.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett, present for ISTM.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACCHO, present.
Morning. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield, representing NAPNAP.
Morning. National Foundation of for Infectious Diseases.
Good morning. This is Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and Medical Director of the NFID.
Thank you. National Medical Association.
Good morning. This is Pat Whitley-Williams, Professor of Pediatrics. I'm a pediatric ID physician at Rutgers Robert Wood Johnson Medical School.
Thank you. Pediatric Infectious Disease Society.
Good morning. Sean O'Leary, representing PIDS.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Good morning. It's Amy Middleman, representing SAM.
Thank you. And Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care in Delaware, representing SHEA.
Thank you, everyone. Are there any individuals who have arrived after roll call that would like to announce themselves? Okay, perfect. Thank you, everyone. Thanks for your patience. Before we get started, I would like to ask if Dr. Doran Fink from the FDA would like to make a few comments and provide any updates to the committee. Dr. Fink?
Hi, Dr. Lee. Thank you for asking. I actually have two announcements to make today on behalf of FDA. First, and this is one of the discussion topics for the ACIP today, I would like to announce that, as many of you already know, on Monday, January 31st, FDA approved Spikevax, also known as the Moderna COVID-19 vaccine, is used under emergency use authorization as a 2-dose primary series for use in adults 18 years of age and older. FDA's approval was based on both updated data and analyses from the same phase 3 clinical trial involving approximately 30,000 participants that initially supported emergency use authorization of the vaccine back in December of 2020. And also our approval considered real-world experience from post-authorization use of the vaccine in many millions of individuals. In the updated efficacy analyses, which included a median placebo-controlled blinded follow-up of 4 months, vaccine efficacy against any symptomatic COVID starting 14 days after dose 2 was approximately 93%, and vaccine efficacy against severe COVID was approximately 98%. The review of safety data from additional follow-up conducted in the clinical trial, as well as from post-authorization experience, did not raise any new safety concerns compared to the safety profile that was previously labeled in the emergency use authorization fact sheets. Important but very uncommon adverse reactions continue to be anaphylaxis, as well as myocarditis and pericarditis, in particular following dose 2, and in particular among males less than 40 years of age. And the approved U.S. prescribing information for Spikevax includes warnings about these adverse reactions, and they will continue to be followed through post-marketing surveillance. We recognize that approval of the biologics license application for Spikevax represents an important step in building and maintaining our armamentarium of countermeasures against COVID-19, as well as an important regulatory step for this particular vaccine. It will certainly not be the last step. There are other uses of this vaccine, for example, booster doses that are currently available under emergency use authorization, and work is ongoing to eventually transition some of these things over to licensure. And additionally, we anticipate that in the future there will be supplements to the license or amendments to the emergency use authorization to address other needs as they arise. The second announcement that I would like to make today involves the upcoming meeting of the Vaccines and Related Biological Products Advisory Committee scheduled for February 15th. That was announced publicly by FDA earlier this week. In mid-December, Pfizer-BioNTech announced initial safety and immunogenicity results from infants and children 6 months through 4 years of age enrolled in their ongoing clinical trial of the Pfizer-BioNTech COVID-19 vaccine, and also announced their plans to amend the trial to evaluate the third dose of the vaccine in this age group. As reports of pediatric hospitalizations increased in association with the Omicron variant surge in late December, FDA requested Pfizer to provide more detailed data for our review as the information became available. At the same time, FDA has received many inquiries from healthcare providers, from advocacy groups, and from the general public expressing intense interest in the details of the data and prospects for emergency use authorization of the vaccine for use in this age group. During our ongoing review, we recognized that additional immunogenicity and efficacy data have become available to better inform vaccine benefits. In the meantime, while the Omicron surge is now receding in some parts of the nation, it's certainly not over. Furthermore, it is imperative not only to react to the present situation, but also to be prepared for when we are confronted with the next unexpected twist. The decision to hold this VRPAC was not only motivated by the need for transparency on the newly available data, which will be addressed through the meeting briefing documents, presentations, and discussion, but also motivated by the defining unpredictability of the pandemic. FDA intends to conduct an open, transparent, and thorough discussion of the available data, to listen carefully to the assessment of our expert committee members, and to end the meeting better prepared to build upon our response to COVID-19, whether this follows from a clear recommendation for an authorization or from recommendations for additional data that could support an expedient authorization in the near future. Thank you.
Thank you, Dr. Fink. And again, thank you to the FDA for your continued work on all of the myriad of issues that continue to come up during this pandemic. So we will now move on to the first session for the day. During today's meeting, as a reminder, I'll invite individuals to contribute to the discussion. Please raise your hands electronically, and I will call on ACIP members first, followed by our ex officio members and liaisons. But before we get started, I wanted to ask if Ms. Bata is able to unmute and provide her name, affiliation, and whether she has any conflicts of interest.
Good morning. I am here. This is Lynn Bata. I am a immunization clinical consultant with the Minnesota Department of Health, and I have no conflicts.
Thank you, Ms. Bata. And we will start today with Dr. Matt Daly, who is chair of our COVID-19 vaccines workgroup, to provide an introduction and overview of today's meeting. So Dr. Daly.
Great, thank you so much. So I will be introducing today's sessions. I'm presenting on behalf of the ACIP COVID-19 vaccines workgroup. Next slide, please. So through January 30th of 2022, there have been nearly 75 million cases of COVID-19 in the United States. And although case counts have been declining in the last several weeks, we're still averaging hundreds of thousands of cases of COVID-19 every day in the US. Next slide, please. And during the pandemic, more than 880,000 individuals in the US have died from COVID-19. And based on the most recent 7-day moving average, more than 2,000 individuals will die today from COVID-19. Next slide, please. So this figure shows rates of COVID-19 death by vaccination status. And the black line shows rate of death from COVID-19 for the unvaccinated, and the blue line shows rate of death for the fully vaccinated. And this can be viewed as a visual representation of real-world effectiveness, real-world evidence of high vaccine effectiveness. But I also see something else. The space between the black and blue lines here is lives saved by vaccination. Next slide, please. So to achieve disease prevention, it takes not just having an effective vaccine, but an effective vaccination program. There needs to be adequate vaccine supplies, the people, the processes to administer vaccines, and in addition, the public needs to be accepting of vaccines. And as you can see in this graph, across every adult age group, more than 3/4 in the United States have received at least one dose of a COVID-19 vaccine. And while I fully recognize that these are lower vaccination rates than perhaps we would have hoped, and I hope they continue to rise, this is still an important accomplishment. Next slide, please. So there have been several recent studies that have tried to estimate COVID-19 associated hospitalizations and deaths prevented by COVID-19 vaccination in the United States. And based on these new studies, it's been estimated that up to 10.3 million hospitalizations have been averted through November of 2021 through vaccination. and an estimated 1.1 million deaths have been averted through November 2021 by vaccination. Next slide, please. So here are a number of FDA updates. Dr. Fink just went over these very well, so I won't read them. I will highlight, though, something that Dr. Fink mentioned, which is that the Moderna COVID-19 vaccine remains under emergency use authorization for the following indications: when it's used as a third dose in the primary series for individuals with moderate to severe immunocompromise, and when it's used as a booster dose. Next slide, please. So here I want to review the COVID-19 vaccines workgroup activities for the months of January and February of 2022. The workgroup reviewed data on the safety and efficacy of Moderna COVID-19 vaccine from the phase 3 clinical trials. In addition, reviewed meta-analysis for the global real-world effectiveness data from Moderna COVID-19 vaccine. In addition, the workgroup reviewed safety updates for Moderna COVID-19 vaccine specifically and for mRNA COVID-19 vaccines in general. In addition, the workgroup looked at the grade and evidence to recommendations framework data for Moderna COVID-19 vaccine primary series. In addition, the workgroup did review global data for myocarditis after mRNA COVID-19 vaccines. And then finally, the workgroup, in addition, looked at emerging data about safety and effectiveness of longer interdose intervals for mRNA COVID-19 vaccines. Next slide, please. So here's the agenda for today. First, we'll hear from Dr. Rita Das from Moderna, who will review mRNA 1273 COVID-19 vaccine biologics license application safety and efficacy data. This will be followed by a break. After that, there'll be a public comment period. After the public comment period, we'll hear from Dr. Shimabukuro at the CDC, who will present updates on myocarditis and pericarditis following Moderna COVID-19 vaccination. After that, we'll hear from Dr. Krasolek from the CDC, who will give us an update on the MOVING study, which is looking at longer-term outcomes following vaccine-associated myocarditis. After that, we'll hear from Dr. Talbot, who's the VAST chair. And VAST is the Vaccine Safety Technical Subgroup, and she'll provide VAST assessment of the current state of knowledge around COVID-19 vaccine safety, specifically focused on Moderna COVID-19 vaccination. Following that, we'll have a break. Following that, we'll hear from Dr. Wallace, who will present the grade evidence around Moderna COVID-19 vaccine. Following Dr. Wallace's presentation, we'll hear from Dr. Oliver, who will present evidence to recommendations framework regarding the use of Moderna COVID-19 vaccine for a primary series in individuals 18 years of age and older. After that, we'll have a discussion. After that, we will have a vote on the routine use of Moderna COVID-19 vaccine for individuals 18 and older. Next slide, please. Following the vote, then we'll hear from Dr. Hall from the CDC, who will provide updates to clinical considerations. Following this, we'll hear from colleagues to the north. This is from the Public Health Agency of Canada, Dr. Tunis, Dr. Warshawski, and then we'll hear from Ms. Ogunake Cook. They will present the Canadian experience and evidence with COVID-19 vaccine primary series extended intervals. Following this, we'll hear from Dr. Klein, who's from Kaiser Permanente, Northern California. She'll present VSD data on myocarditis after Moderna and Pfizer-BioNTech COVID-19 vaccines. Following this, we'll hear from Ms. Malia from the CDC, who will present regarding myocarditis and COVID-19 vaccine intervals, international data and policies. And then following that, we'll hear from Dr. Oliver from the CDC, who will present a summary and workgroup interpretations of extended intervals for mRNA COVID-19 vaccines, after which we'll have additional time for discussion. Next slide, please. So on this slide, we list the COVID-19 vaccines workgroup members who've been tremendously helpful in all of this. This includes ACIP members, ex officio and government members, liaisons and consultants, as well as the outstanding leadership of Dr. Sarah Oliver. Next slide. And then this slide shows a number of individuals from the CDC who are essential to the work of the COVID-19 vaccines workgroup. Next slide, please. And then I will turn it back to you, Dr. Lee.
Thank you, Dr. Daly. With that, we'll move on to Dr. Rita Das from Moderna, who will be presenting on mRNA 1273 COVID-19 vaccine BLA safety and efficacy data. So Please go ahead, Dr. Duff.
Thank you so much. Good morning. And thank you again to the ACIP for their diligent efforts throughout the pandemic. I'm pleased to present an overview of the BLA for the Moderna COVID-19 vaccine, or Spikevax, which was approved at the beginning of this week. We will discuss the contents of the BLA, the phase 3 safety data, and then the efficacy data. As was just mentioned, this approval includes the administration of the primary series in individuals 18 years of age and older. The follow-up time included is 5.3 months for the blinded study, that's post-vaccination, and 7.6 months for the blinded and open label phases of the study together. The BLA does not include the authorized indication for a third 100 microgram dose for immunocompromised populations, as well as the indication for the 50 microgram booster. The data for the Omicron variant also are not covered in this presentation. I'm going to move to my next slide. I just wanted to confirm that the slides are advancing for everyone.
Yes.
Okay, great. Thank you. So again, Spikevax is indicated for the immunization to prevent COVID-19 caused by SARS-CoV-2 in individuals 18 years of age and older. It's administered as an intramuscular injection in a series of 2 doses with a 0.5 ml volume 1 month apart. And again, the dose is 100 micrograms. So I'll take you through Protocol 301, or the Cova trial, which is the pivotal safety and efficacy study. The study enrolled 30,400 people who were randomized 1-to-1 to receive the vaccine mRNA 1273 or placebo, about 15,200 in each group. The study started in July 2020 and completed enrollment by October 2020. The initial efficacy readout came from the interim analysis, which was at the end of November. That led to the approval of the EUA on December 18th. Thereafter, participants were offered unblinding and placebo recipients were allowed to be vaccinated. All participants were then continued to be followed in an open label manner according to the original schedule of events. So in the next slide, I have the details of the schedule of events of the study. So at baseline, all participants had a nasopharyngeal swab and a blood sample to assess their SARS-CoV-2 status. After vaccination, everybody was given an e-diary to monitor solicited adverse reactions for 7 days. Unsolicited adverse reactions were monitored via weekly phone calls for 28 days. The same thing repeated after dose 2. Serious adverse events, medically attended adverse events, and adverse events leading to discontinuation were to be monitored for the duration of the study, which is planned to be 2 years. Throughout the study, also, case monitoring was conducted through weekly e-diary prompts and monthly phone calls. If the participants met the criteria for an illness visit, they came into the site, had a sample collected for central lab testing, and then participants were followed daily through telemedicine contacts for 14 days or until the resolution of symptoms, whichever was longer. Additional clinic visits were planned for 3, 6, 12, and 24 months after vaccination. So the mean age of the population in the study was about 52 years old. The goal of the study was to enrich for populations most affected by severe COVID-19. Accordingly, 25% of participants were greater than 65 years old, about 1,500 were greater than 75 years old, and another 17% were 18 to 64 years old with comorbid conditions like chronic lung disease, significant cardiac disease, obesity, liver disease, or HIV. and the HIV group had about 90 participants in the vaccine and placebo recipients. We had assessed baseline SARS-CoV-2 status, and approximately 2% of participants had baseline evidence of prior SARS-CoV-2 infection. So the racial and ethnic distribution of the study was generally similar to the US population, and this was a key objective in the recruitment of the study. There were 10% Black or African American participants and 20% Hispanic or Latino participants in the study. So now on to the safety. So once again, after each dose, solicited reactions were followed for 7 days, unsolicited for 28 days, and serious adverse events, medically attended adverse events, and adverse events leading to discontinuation were followed for the whole study. Solicited injection site reactions were more common among vaccine recipients compared to placebo recipients. This slide shows the solicited local reactions after dose 1. Injection site pain was the most common reaction, and the slide is also broken down by 18 to 64 and above 65, and local reactions were very similar between the two age groups. So the next slide here shows the solicited local reactions after dose 2, which were very similar. Again, mostly grade 1 or grade 2. Overall, local reactions were also of short duration and generally resolved in 1 to 3 days. Delayed local reactions with an onset after 7 days were seen, but were relatively rare, occurring in 2.4% of vaccine recipients and 1.4% of placebo recipients. Now on to the solicited systemic reactions. Again, for the solicited systemic reactions, most were grade 1 or grade 2 and were observed more frequently in the vaccine compared to the placebo recipients. Fatigue and headache were the most common reactions. And then on the next slide, so this is post-dose 1. On the next slide, I have post-dose 2. And we saw in the trial, as it's seen certainly in practice, that solicited reactions were more common post-dose 2 compared to post-dose 1. Older, greater than 65-year-old participants had a numerically lower reactogenicity compared to their younger counterparts. The duration of solicited systemic adverse reactions were also short, ranging from 1 to 3 days. So now on to unsolicited events. So unsolicited events occurring within 28 days of vaccination were similar among vaccine and placebo groups. Medically attended adverse events, serious adverse events, and deaths were also similar. And here we have the system organ class breakdown for the serious adverse events which occurred in the study. And as you can see here, the blue is the mRNA 1273, the gray is the placebo, and the occurrence, the system organ class of the solicited, of the serious adverse events were generally balanced. The same was noted for the medically attended adverse events, and I'm not showing you the graphic here. So next, looking specifically at myocarditis and pericarditis. During the blinded or the open label periods of the study, there were no myocarditis events. For pericarditis, in the blinded phase, there were 2 events in the vaccine group and 2 events in the placebo group. I'll go through the events in the vaccine group. The first one, the event that was considered related, was a 59-year-old woman with some symptoms 4 days post-dose 2, who then experienced chest pain and syncope 2 months later, when pericarditis and an effusion were diagnosed. This was considered related. The other case was a post-myocardial infarction pericarditis, which was considered unrelated. Now on to the open label phase. In the open label phase, again, no myocarditis was observed. There was one pericarditis event in a 23-year-old male who had COVID about 2 months prior to vaccination, and subsequent to vaccination, he developed bradycardia and was diagnosed with a pericardial effusion. This was also classified as a vaccine-related event. All of the events of pericarditis that occurred in either the blinded phase or the open label phase of the study resolved. Now on to efficacy. As a reminder, 30,000 participants were randomized to vaccine or placebo. The first read on the efficacy was at the interim analysis conducted in November of 2020, which showed the 94.1% efficacy. For the BLA, the final blinded analysis was performed with 5.3 months of follow-up that was calculated post-dose 1, and that was through March of 2021. Subsequently, the study entered the open label phase and placebo recipients were offered vaccines. Effectiveness has been followed since then in an open label manner. Additionally, boosting of study participants started in September of 2021 and is ongoing. So here's the final blinded analysis of efficacy, and the results were very similar to the initial interim analysis. There were 700, this is the COVID-19 infection endpoint, and there were 744 cases in the placebo group compared to 55 cases in the vaccine group for an efficacy of 93.2%. The median duration of follow-up here was 5.3 months. Since the study was conducted between July 2020 and March of, or since the blinded period of the study was conducted between July 2020 and March of 2021, the predominant SARS-CoV-2 variants identified in the majority of the COVID-19 cases were sequenced to be either the original or the alpha variant. Some additional variants that were identified included epsilon, gamma, and zeta. The case numbers for the other variants was small, but there was no indication that efficacy against other variants was impacted. Of course, there was no Delta or Omicron circulation during that time. So looking closer at the efficacy during various time periods, the efficacy was consistent and durable over the observation period. High efficacy started after vaccination and was maintained very consistently through greater than 4 months after vaccination. Vaccine efficacy to prevent severe COVID-19 was also consistent, with 106 cases in the placebo group and 2 cases in the vaccine group for an efficacy of 98.2%. Now here's a slide of all of the different endpoints. I already discussed the COVID-19 overall, the severe COVID-19, but here you also have SARS-CoV-2 infection regardless of symptoms, COVID-19 by the secondary or the CDC definition, deaths related to COVID-19, and COVID-19 efficacy starting 14 days after the first injection. And all of these were extremely consistent. Even asymptomatic infection was prevented by vaccination with an efficacy point estimate of 63%. Efficacy regardless of baseline serostatus also was consistent. The group sizes and the number of cases, however, became too small for an analysis on baseline SARS-CoV-2 seropositive only. Now here is efficacy by demographics. Efficacy was consistent across age. Greater than 65 had very high and consistent efficacy, and greater than 75 also had very high and consistent efficacy, although the case numbers did become small here. Efficacy also was consistent across race and ethnic groups. I'm not showing the data here, but efficacy for comorbid conditions, the ones that were targeted to be recruited in the trial, were also similarly consistent. So in summary, mRNA 1273 was well tolerated in individuals greater than 18 years old. Pain was the most commonly reported local reaction. Fatigue, headache, myalgia, and arthralgia were the most commonly reported systemic reactions. Systemic reactions were more common after dose 2 than dose 1. And there was no difference in adverse reactions for 18 to 64 versus greater than 65 years of age. And then after a median of 5.3 months post-dose 1 of efficacy follow-up, there was 93.2% efficacy against COVID-19 starting 14 days post-dose 2, 98.2% efficacy against severe COVID-19 starting 14 days post-dose 2, 82% reduction of infection regardless of symptoms, and 63% reduction in asymptomatic infection, all of this starting 14 days post-dose 2. Efficacy was consistent regardless of risk factors, age, gender, or race or ethnicity. So with that, I will conclude my, my presentation. I certainly need to acknowledge all of our collaborators and partners, all of the investigators and study personnel at the site, our colleagues at BARDA and IAID, and the laboratory at Duke University. And most importantly, I'd like to thank our trial participants whose dedication to the trial really made all of this possible. Thank you very much, and I'm very happy to take questions.
Thank you, Dr. Doss. This presentation is now open for questions. And I see, Dr. Paling, you have your hand raised.
Yes, good morning, and thank you, Dr. Doss. This is a fabulous presentation and really appreciate all the detail, including going through the results by race and ethnicity. The question I wanted to ask is, have you had a chance to look at the vaccine effectiveness for persons with and without comorbid conditions? Thank you.
Yes, absolutely. We have looked at all of the comorbid conditions, respiratory disease, cardiac disease, obesity, HIV. All of the efficacies were very consistent, above 80% for all of the comorbid conditions.
Thank you. Dr. Lair?
Thank you for this presentation. Could you please go to slide 8? I was wondering how you did the asymptomatic data. I didn't see that when you were looking at testing, and I didn't think it was probably from the blood test that you had at day 200 something or other.
Yes. So asymptomatic infection, and we did not do weekly or every 2 week screening for asymptomatic infection. These numbers came from the nuclear protein assays, which were done at every time participants had a blood draw. So, and as well as every time participants came into the study, into the site for a visit, they had a nasopharyngeal swab. So we took all of those positives and then checked to look whether there were any symptoms pages that were documented in the CRS. And so that's how, so the participants who had positives, either by serology or by PCR and P-swab scheduled at routine times, but did not have any symptoms, contributed to the asymptomatic infection analysis. I think it provides a good directional estimate, but it's certainly not a priori weekly or every other week screening for asymptomatic infection.
Thank you. And then if I could have one more question. If you could go to page 26, your curve flattens out for the placebo there. And I'm just wondering, why would it flatten out if you're still getting more cases? I just didn't understand that. Thank you.
Yeah, I think we still were subject to the ebbs and flows of the overall trajectory of the pandemic. That's what I can come up with for the curve flattening out. Our COVID-19 infection curve does the same. So I think the most, if I would speculate, it would probably be because of kind of the trajectory of the pandemic at that time.
Thank you, Dr. Lair and Dr. Doss. Are there any additional questions for Dr. Doss? Dr. Sanchez.
Thank you, and thank you for that presentation. Certainly, it's it's great data and very encouraging. I had a question on the deaths. On your slide 18, any death that was reported was 16 in the vaccine group, and then placebo was also 16, certainly similar. But then you really, so then you finally analyzed only the COVID-related deaths, right, in the number of events. Do you know what these deaths were due to?
Yep, so these are the total, these are actually the total deaths. The COVID-related deaths analysis was 3 deaths in the placebo group and no deaths in the vaccine group. Let me actually take the slide down for a second, and I will get to the all deaths slide. Apologies, bear with me for a second. Yeah, and so just while I'm getting to the slide, none of the deaths were considered related to vaccine, and kind of the number of deaths were really reflective of the type of population that was enrolled, with multiple comorbid conditions. And so here we go. I can show you. Okay. Into presentation mode. Yeah, and so these are the deaths, all the deaths in the study, kind of broken out by vaccine and placebo. And so again, it is, the relationship to treatment is all is not related, and the conditions are reflective of the large size of the population and the comorbid conditions of the participants who were enrolled. And then here is the, so here's the rest of it. So the database was locked on May 4th, and then all of the data are through the March time point.
Thank you. And I have another question. Were you able to look at development of diabetes? I know this is an older age group, but I presume that was one of the comorbid conditions?
Yes, diabetes was indeed one of the comorbid conditions. As of the new, I think you're asking about the new development of diabetes during the trial. Yeah. Is that correct?
Yes.
Yes, and let me take that back, and I will ask my colleagues if there is a specific dedicated analysis for that.
I know that's been seen more in the children, but it's with COVID, but just was wondering in the adult population.
Yeah, I'm not recalling it as a signal that came out, but let me, I will confirm with my colleagues to see if this analysis was specifically done.
Thank you.
Thank you. Dr. Long?
Yes, thank you so much. I know that we've seen about severe disease, hospitalizations, and death, but the question is about infection, be it symptomatic or asymptomatic, and the protection against those kinds of infections not leading to hospitalization over the even short time of the study. Meaning increasing days since your first dose, second dose, whatever.
Yeah. So, I mean, our protection by the time frames that we looked at was extremely flat. So, we did that, and I showed you the COVID-19 analysis by time frame, and it was extremely flat. All of the always like consistently at 90, we did the same for the other endpoints. Again, those were all flat as well. indicating the consistent and not waning protection over the period that was assessed in the study. The COVID-19 endpoint was 2 symptoms plus the positive PCR, but then we also looked at the more permissive or perhaps more kind of relevant to your question, the CDC case definition, which only required 1 symptom plus the positive PCR. And there again, the efficacy was very consistent.
Thank you.
Thank you. Are there any additional questions for Dr. Das? Dr. Paling.
Yes, I wanted to ask about anaphylaxis in the trial. Could you share the results on that? Thank you.
Yes, absolutely. Let me pull that up. Okay, yes. So anaphylaxis was reported in 2 participants. So it was actually balanced between the vaccine and the placebo group. In the placebo group, an anaphylaxis was reported in 2 participants on day 10 and day 11 after the first injection. And then among the vaccine groups, it was also reported in 2 participants. And the anaphylaxis events in the vaccine group were actually reported a bit later, almost 2 months after the second dose. Both were considered not related. And so, although there was not an imbalance of anaphylaxis that was seen in the trial, anaphylaxis, of course, is listed in the label as a possible side effect.
Thank you very much. Last call for questions. Okay, Dr. Sanchez.
I was just interested in learning a little bit more about the pericarditis in the 23-year-old male who, it sounds that it was after the vaccine, but he had been in the placebo group and had had COVID previously. And do you know what the severity of that COVID infection had been? Because he was diagnosed with COVID and he was placebo, and then he got the first dose of the vaccine, and then subsequently after dose 2 is when he developed the pericardial effusion. Do you know the severity of that COVID-19 infection? Had he had some more? Was he hospitalized? Had he been, because this is an issue that comes up is after COVID and after having COVID, when do you vaccinate and how long do you wait and what other should you? I was just wondering if you knew the severity of that COVID-19 infection.
So he was not hospitalized or did not meet the criteria for severe COVID because he was because this participant was one of the cases in the in the blinded phase of the analysis. Beyond that, yes, I'm getting a confirmation that the COVID case was mild. That is the information that we have, that 43 days after dose 2, he was diagnosed with bradycardia and a pericardial effusion. And there was some kind of bradycardia prior to that, which was not associated with any chest pain.
And it was 2 months, and the first dose was 2 months after receiving that first COVID, the first dose. Okay.
Yeah, so he had COVID with mild symptoms. Then 2 months later, after the unblinding of the study, he received the first dose of the vaccine, then received the second dose of the vaccine a month later. And then subsequent to that, there was some bradycardia that was noted. And about 43 days after dose 2 was diagnosed with a pericardial effusion and pericarditis.
Thank you.
Thank you. I'm going to actually suggest that we take a break. So we'll thank our presenters, and we will now recess until 10 minutes after the hour, after which we will return for a public comment session. Thank you, everyone.